all enjoyed your short tea break. Now let's get back on track. I look forward to begin our next session, that is on Symposium on Chronic Constipation Part A, Consensus and Treatment. For the session, inviting Dr. Manisha Dwivedi as a moderator. Kindly come on the stage, ma'am. And our chairpersons, Dr. Nisarg Patel, Dr. Amol Dahale, Dr. Uma Venkatesha, Dr. Akhil Jindal. All the chairpersons, kindly come on the stage.
Good morning, everybody. We go on to the next session. That's a symposium on chronic constipation, consensus and treatment. You'll all agree with me that this is a very important topic and which we all encounter. And sometimes it's extremely vexing because the constipation is refractory and you don't know what to do with the patient. In this session, we have 4 important talks. The first would be given by Dr. Matthew Philip. He's the head of the department in the Lisi Institute of Gastroenterology at Kochi. And he'll be speaking to you about consensus guidelines for chronic constipation, East versus West. Dr. Matthew Philip, please.
Thank you, Chairpersons. First of all, I would like to thank the organizers for giving this opportunity. Is chronic constipation common in India? It's generally a popular belief that constipation is infrequent in India when compared to the West. This is basically because of the vegetarian food we take, high fiber intake of the people of India. Then generally the frequency of bowel movements is more in patients of India. So probably chronic constipation might be underreported in India. This is because the studies have shown that this is prevalent in India, and of course we know that self-perception is constipation is much more than the true constipation. So in my discussion, the guidelines, I'll be touching upon these points, and my discussion will be based on 2 major publications of latest, one from Europe and another from India. And my discussion will be based on approach to constipation and guideline discussion. This is a case, 42-year-old male, chronic constipation of 3 years, and passes stool almost every day. History of abdominal pain gets better with passage of stool. He remains well for a few months and then again recurrence. Also has bloating sensation. Another is 60-year-old female, aspiring to become a doctor, chronic constipation 10 years, passes stool every 7 to 10 days, no urge to pass stool, abdominal pain often. Third case is a male of 46 years, constipation for 15 years, pass 2 to 3 stools per day, feeling of incomplete evacuation, straining, persistent urge, heaviness in the lower abdomen, and evacuation with finger often. So when you look at the diagnostic and therapeutic strategy of constipation, we need to know what it is. How do you classify constipation? You know the patient factors involved in that and map the disease and treat and optimize. So this will be based on the guidelines which I discussed. Classical definition of constipation is less than 3 spontaneous bowel movements a week and associated with many other factors like hard stool, less volume stool, many other feeling of incomplete evacuation. So it is many times it's a self-diagnosed or constipation or a perceived constipation. So there should be a difference between perceived constipation versus true constipation. But in India, constipation is better defined by stool forms and patient perception rather than by the stool frequency. You have symptom complex and stool characteristics. And we have less than frequency there and different other parameters. And it must include at least 2 or more to label them as constipation. And it should be there for at least 3 months, and the symptoms onset at least 6 months prior to the diagnosis. And this is the stool chart, which I'm not going to detail. Looking at the types of constipation, we know that it can be functional or organic. Functional is much more than organic, and there are 3 types: normal transit constipation, slow transit, and pelvic dyssynergia or evacuation disorder is in the functional group. Functional group mimics very commonly mimics with that of IBS-C. And original organic can be mechanical causes like obstruction, etc., drugs or systemic causes. There can be considerable overlap between these two also. At rest, this is the bowel and anorectal junction, you know that. Stool comes and rests at the rectum. And during defecation, the you can pubic rectalis relaxes and the muscles relax and it is pushed down and you have a normal defecation. But what happens in anorectal discoordination? There is stool stored there. Partially it goes, but there is an incomplete evacuation because of the abnormality of anorectal region. There is hard and dry stools, straining, persistent arch, manual evacuation, etc. How do you approach to constipation? Is the constipation functional or organic? Does it fulfill criteria for IBS? Does it have features of slow transit or it has got evacuation disorders? Functional or organic, we need to know whether there are alarm symptoms or not. Organic has got new onset symptoms, weight loss, anorexia, bleeding manifestations, etc., etc. Our family history of so like that. So differentiating these two has one symptom very common and one sign very important. And the feeling of urge. In normal transiting, feeling of urge will be there. And in dysenergia, there is persistent urge. And slow transit, no urge at all. And one sign is rectal examination. You are looking at all these parameters, and it can actually give a good idea in 73% of patients what you are dealing with. And what are the approach for chronic constipation? The investigations. When there are alarm features, you need to investigate in detail, and you need to rule out organic disease like inflammatory diseases or strictures, and you should do a colonoscopy or an imaging test. And when there is no urge, there is chronic constipation, could be a slow transit, or in an evacuation disorder, you need to pelvic floor function and studies. You need to do a colonic transit, or you need to do a manometry and difficography, etc. Colonic transit study, basically we follow what Dr. U.C. Gosal and team has told, and this is actually a normal transit. You can see the less than 10 number of markers in the abdomen at 60 hours, and this is actually a slow transit with plenty of markers. And evaluation of pelvic floor, we have two tests. We can have anorectal manometry or MR or barium difficography. Manometry will tell you what the types of abnormalities can be type 1 or up to type 4 is there. And this is actually a MR difficography. You can see that the patient is actually passing motion in real time, and what you see is there are descent as well as rectocele, and the angle also gets paradoxical movement there. And this is the pubococcygeal line, and here you can see a significant descent down. So coming to the back, the history, the first patient has irritable bowel syndrome. The second patient has more likely done so slow transit constipation. And the third patient has pelvic floor dysenergia. How do you treat these patients? Basically, we need to, for a normal defecation, you need a patent tract for defecation. You need to have appropriate stool bulk or water content there, appropriate intestinal motility to push the material down, and there is a normal functioning defecatory apparatus. And what you do is, you do lifestyle modifications and other treatment modalities, which I am not going to detail. So in summary, what you do is what it is. We know that there is perceived and true constipation, and classify the constipation into functional, organic, and if it is functional, normal transit, slow transit, or dysenergia, and know patient factors like age, setting, comorbidity, rehability, etc., and map of the disease, especially urge and digital rectal examination are very important, and treat. We have what first line, second line, and combination, rotation, etc. So coming to the guidelines, and last few slides, we know that, as I told you, I have compared with India and West, and definition, we know that it is in West, it is less than, it's basically depend on frequency of the motion. And ideally, we know that there is a description by Rome criteria, Rome 4, due to lack of time, I'm not showing you that. But in India, it is based on form and perception rather than by the stool frequency. In India, epidemiologically, it is underreported. In Western countries, it's quite common. Globally, it is around 14%, and females are more common in all our countries. Globally also, in India, it is true. It is basically because of the hormonal factors like progesterone, obstetrical cause, etc. Socioeconomic status, in the West it is written that so low socioeconomic status because of the low fiber intake, low intake of vegetables and fruits which are costly there, they have a high chance of constipation. But in India, data is not available. In family history, in India, we don't have enough data to say that it is related, but in Western countries, it is said it is related. And the form of stool, in India, constipation is BSFS up to 3, 1 to 3 are considered into the group of constipation, but in Western countries, it's type 1 and 2. Frequency, we know that West it is less than 3 per week, but in India, normal people pass stool around 2 to 3. So the constipation frequency is not important, and we have to look at other features. The most frequent symptoms of chronic constipation is straining and hard stools, and in India it is along with other features also. Because the formation, the form, even I told you, 3 is also a part, BSFS 3 is also a part of it. But in West, the predominant symptoms are straining and hard stools. Recommendation of ROM 4 criteria for diagnosis of functional constipation. In India, at present, it is not practiced clinically, but in probably yes, in research and academic centers. And in Western countries, it is recommended for all, but not practiced in the primary care. And functional constipation is more common than IBS-C in India because abdominal pain, that actually denotes whether there is functional constipation, IBS-C or not. In India, it is a recommendation. West, it is not because they actually think, IBS-C, definitely abdominal pain is there. In our IBS-C, probably abdominal pain may not be important, and there is a lot of overlap between functional constipation and abdominal bloating is quite common in India. As well as in Asia, but not mentioned as a criteria. It is mentioned, but it's not a criteria in Western. Psychological issues are common in patients with the chronic constipation. It's a recommendation in both the group. And prevalence of rectal hypersensitivity, data is not available in India, but it is increased in the Western literature. Volume of interstitial cells in the biopsy or resected specimens in the sigmoid colon, we have no data available, but Asian studies are available. And it is shown that in Western country literature, it is decreased, especially in slow transit and chronic constipation. Functional testing is recommended when the first-line therapeutic measures have failed to improve symptoms. It is recommended in both guidelines. Difficography is indicated in refractory evacuation disorder. There is no recommendation in a sense, but we know that it is written that in Indian guidelines, a combination test, including difficography, may be more yielding than a single test or 2 tests. In Western countries, it is being recommended. SRUS is associated with fecal evacuation disorder, and it is recommended in India, but it is not recommended in Western guidelines. Bristol stool form correlates with colonic transit, and we know that our patients have got a low transit time, and it is recommended in our literature. And biofeedback is preferred treatment for functional defecation disorder. It's a recommendation, and in fact, our guidelines say it is the first line of treatment. And the West, it is a recommendation, but it is not the first line of treatment suggested. Indian toilet is more physiological than Western toilet for defecation. That is, there are some early data available, but it is no hard data. Probably physiologically it could be correct because you get a correct angle there. Excessive methane production. You know that it slows the gut transit. It's associated with chronic constipation, and it is recommended in India. Recommendation is there, but there is not data from India. But there are studies available in the Western literature. We know that this is physiologically correct squatting position, probably is correct. And probably my last slide. Colonic transit study, Western protocol may not hold well in India. Because in India, it is a recommendation, and it's a new protocol we follow by Dr. U.C. Gosal, etc. Top-down approach. In certain selected cases, instead of going from below, first-line therapy, second-line therapy, but you may have to start from above, especially when you work in a tertiary center. It is being recommended in Indian guidelines, but not in the Western guidelines. Surgery is reserved for as a last resort in specific functional, especially slow transit, not responding, and of course with structural abnormalities, it is recommendation in both the cases. And we know that the frequency of transit time in India is different when compared to that of Western country. So these are my take-home points. Mechanical causes like neoplasm should be ruled out in patients presenting with chronic constipation by careful history of alarm symptoms and features. Many secondary causes of constipation could mimic functional constipation, especially in metabolic diseases like hypothyroidism and many other things. Drug history is very important and should be checked in all patients who have got comorbidities. Classification of types of constipation, guide to approach and proper therapy. Significant differences are there in the diagnosis and approach of chronic constipation in the West versus East, especially in dietary, cultural, and perceptions. It would be ideal to balance with the Western recommendation and adopt more into Indian guidelines in the management of constipation. Thank you very much, and I welcome all of you to the Varanasi conference, ISC call. The last date of abstract submission is little bit extended. So those who have forgotten to send abstract, please do that. Thank you so much.
Thank you, Dr. Philip, for an excellent deliberation. The talk is open for questions or comments from the House.
Dr. Philip, I have a comment and a question for you, sir. Sir, here. At the back, sir. Yeah.
Okay.
My comment regarding the erectile hyposensitivity, actually in the data for anorectal manometry from DMC Ludhiana we published, we found that patients with functional constipation, they do have a lot more patients have rectal hyposensitivity. And on the reverse, IBS-C patients, they in fact have rectal hypersensitivity. So that was a great difference which we found and we published that. And my question is relating to same that what do you feel these two things, functional constipation and IBS-C, are the spectrum of the same disorder or are they entirely different entities?
The second part is actually difficult to answer because IBS-C and functional constipation, there's a big overlap in that. So unless we have a patient with abdominal pain who has got relief of pain after defecation, we cannot call him as IBS-C. But we know that in India, there is a big overlap between these two, and probably IBS-C of India, the abdominal pain frequency and severity may be less than that of what you see in the Western countries. I agree that I know about the publication, but no, I was just telling about the guideline, the criteria which have been laid upon. That is what I actually told. I agree that it is there.
Any more questions? So if there are none, we move on to the second
Thank
talk.
you.
And that was initially planned to be spoken by Dr. V.K. Dixit. He heads the Department of Gastroenterology at IMS BHU, but he is indisposed. So his talk will be given by Dr. Ghoshal. And he'll be talking to you about the newer drugs which are available to treat chronic constipation.
Thank you so much. As has been said, that actually Dr. Dikshit fell sick. He is sitting here. He cannot speak because of his tooth problem. So last night he asked me to do. So it is my pleasure that I am presenting on his behalf newer pharmacotherapy in chronic constipation. But before I talk about it, I would like to give little bit aspects of how to diagnose constipation, how to subtype, because those are important in therapy, and there could be some overlap with Dr. Matthew Phillips. These are the patent or conflict of interest that I would like to declare. Now, you all know constipation should not be diagnosed by stool frequency alone. Use Bristol stool form chart. And if the predominant stool type is type 1, type 2, Rome says that this is constipation. But in India, we say that type 3 should be included as constipation, and we have enough data from now, not only India but Asia, that type 3 should be included as constipation. So use this in your clinic. Now, this is how we approach this patient, which in length Dr. Matthew Philip covered. This is from Indian Consensus on Chronic Constipation. You may go through it. I'll skip this slide. And then, again, from Indian Consensus on Chronic Constipation, this you should follow so that you can classify patient whether somebody has fecal evacuation disorder purely, or somebody has slow transit plus fecal evacuation disorder, or somebody has normal transit constipation. Pain is very, very important. If pain is there, that means there is a visceral perception issue. So this is IBS constipation. Whereas pain is not there, there is no visceral perception issue. A lot of problem in the gut. Therefore, your therapy should be primarily directed to the gut. So we typically do these 4 tests to subclassify patient with constipation and then go further. This is, I will tell you, it is going to be in the market very soon. This is colon transit marker. The name of this is Transimark. DCGI has already given us the test license. The study has been completed. I have to just deposit to DCGI and then it will be in the market. Now, these are the drugs. And in addition to lifestyle measure, some patient really may have lifestyle issue such as lack of exercise, inadequate fiber in the diet, reduced water intake, very busy lifestyle. These patients should be advised on that. But let me tell you, these don't really work in the clinic, because in the clinic, when the patient come, they have tried all this. It did not work. That's why they have come to us. So if we start advising on this only in the clinic, doesn't work. Most of the patients will say, Doc, I have already tried that, it did not work. That's why I have come to you. Now, osmotic laxative are important, but remember one thing, that if you are giving isopgula husk, if somebody is a bloater, I avoid isopgula husk in them. But if somebody is a vegetarian, again, I try to avoid isopgula husk. Govind Makharia has already shown that these patients take rather excess dietary fiber than what is recommended. Lubiprostone is a good drug. It is a chloride channel activator, therefore it pushes a lot of water into the colon and it works like an osmotic agent, but it doesn't increase bloating so much. But the lubiprostone is a prostaglandin analog, therefore in large dose it can cause nausea and sometimes even vomiting. Remember that. And linaclotide and plicanatide are important drugs because they are guanylate cyclase agonists. So therefore they work like cholera toxin. We are happy that plicanatide is already launched in the Indian market and is available now. Reduced bile acid may be pathogenetically important in constipation. And if you look at the bile acid, we all know that bile acid comes from the bile. And now 95% of this bile acid are reabsorbed from the ileum. This is enterohepatic recirculation of bile acid. Now, and this is done by IBAT. So, what happens is there are ileal bile acid receptor who helps to absorb the bile acid from the ileum. So, if depending upon the IBAT activity, somebody can be having less bile acid in the stool or more bile acid in the stool. If there is less bile acid in the stool, they may have constipation. So, if I can have a drug like this, that this will inhibit the IBAT, what will happen? The ileal bile acid receptor is inhibited in the ileum. The bile acid will be excess in the gut lumen, and therefore this will lead to improvement in the constipation. Again, a good news, Ilobixibat is coming in the Indian market very soon. So, now let me talk about the mechanism of all these drugs. Either they increase motility. For example, prucalopride is a serotonergic agonist. Therefore, it increases serotonin content in the gut. And serotonin is the one which is responsible for movement of the gut. So, the other one mechanism I have already said. Now, if suppose somebody use prucalopride, normal transit constipation, slow transit constipation, is there a difference in the efficacy? Yes. If somebody is normal transit constipation, prucalopride is not good. On the other hand, if somebody is slow transit, there it works better. And if somebody has severely slow transit, in them again it doesn't work because the disease has progressed too much that the drug becomes ineffective. Long-term use, when you are using prucalopride for long time, actually it persists. This is a study which continued using it for 2 years and it was found effective. There was some loss of response with continued use. It may be tolerance to the drug or it may be progression of the disease, because you now know that many of these constipation patients has actually degeneration in their receptors, in the colon for motility. There are molecular mechanisms for slowness and the disease progresses. In fact, there has been beautiful studies which showed that patients who have chronic constipation more often develop Parkinsonism. So first the nerve degenerated in the gut and then it degenerated in the brain. Now, in these patients, typically I take a drug which has a different mechanism of action. Procalopride is a serotonergic agent. Now, on the other hand, look at other drug, for example, bisacodyl, sodium picosulfate, sena. They stimulate high amplitude propagated contraction in the colon. What is HAPC? HAPC is a contraction that propagates in one go through the colon for at least 30 centimeter, with an amplitude of 30 millimeter of mercury at least. And these HAPCs are responsible for movement of the content inside the colon, and this is stimulated by bisacodyl, sodium picosulfate, and sena. So therefore, I add those drugs. If you want evidences, this is a study by Michael Cam. Currently, he is in Australia. He has come back to his home. He was in St. Mark, I think, in London. Yes. Now, this study, multicentric study, he showed that bisacodyl was more effective than placebo. These are studies from India. Dr. Hari's very famous study on tegaserod, which we do not have in market anymore. And this is another study which is again from India. Now, in patients who are refractory, I sometimes do a hydrogen breath test. Lactulose is better than glucose for estimating methanogens in the gut. So what we do is we do a hydrogen methane breath test using lactulose, and if we find high methane, we reduce the amount of methane using rifaximin. There are 3 studies in the world, 2 from Mark Pimentel group from California. One is retrospective, and other was a randomized control trial. However, in this study, he did not do any transit study, and our one, we did also transit, and we found that rifaximin reduces methane. Therefore, it improves colonic transit because methane is a nerve gas. It slows the gut transit time. It also depletes serotonin. And now, with methane reduction, there is improvement in the transit. Now, when all these fail, what do we do? These are not real pharmacotherapy, but I have to summarize this. Rectal irrigation is very, very useful. Fecal evacuation disorder patients, don't load them with a lot of laxative, because the gut is 9 millimeter in length, and don't expect you can pour the gut with huge amount of those osmotic agent and they will work down below in the rectum. So their rectal irrigation is very useful. In fact, there is a machine called Peristeen, very simple machine. I tell my patient who are having connection in the UK to get it from there. The machine is not available in India. I talked with the people who are marketing this machine, but somehow it is not there in India. We sometimes gives Botox injection into the sphincter. Electrical stimulation, for example, TENS for the sacral nerve branches in the lower limb may help. Satish Rao has described a capsule which is a vibrating capsule, and the vibrating capsule was coming to India, but somehow it did not materialize. So what it does is it goes to the colon and start vibrating inside the colon, and probably this stimulates HAPC, and therefore you spend some money to defecate in the morning. I would say this will be a very good rescue therapy if we had. Now, this is a very important issue that Ravinder Mittal asked in the free paper session. We are talking about colonoscopy preparation, use of yoga. It works, yes. But at the same time, colonoscopy preparation is less of a problem than improving constipation. There is a lot of unmet need in the management of constipation, and we need to try yoga in the management of constipation. Thank you so much.
Thank you, Dr. Ghoshal. The organizers want the question and answers to be at the end of the session. So may I request you to join us on the dais, please, Dr. Ghoshal.
Moving ahead, we have a next interesting talk on inorectal high-resolution manometry and London classification. And we have a very experienced speaker for this. I invite Dr. Manish Paliwal, who is a senior consultant at PSRI Hospital, Delhi. He will deliberate on this topic.
Thank you, respected chairpersons. I am Manish Paliwal. First of all, I would like to thank Professor Ghoshal for giving me an opportunity, and I would like to thank the organizers. My topic assigned is anorectal manometry and London classification. We've all heard on manometry. I'll not be going into details of equipment. We all know that patients who present with anorectal symptoms may have constipation, difficult evacuation, fecal incontinence, anorectal pain, rectal bleeding, and rectal prolapse. It has to be understood that a functional aspect has to be seen and structural aspects should be ideally ruled out, except in certain cases. So the anorectal manometry represents a dynamic measure of the intraluminal pressure, and it enables us to evaluate objectively both parameters of anal and rectal function. What are the indications? The current indications are in cases of fecal incontinence to look at the impaired anal sphincter function or rectal sensations. Also to look at the recto-anal coordination in case of constipation, especially with evacuation disorders. It has to be evacuation disorders, functional anorectal pain, in preoperative assessment of anorectal function, also to quantify the people who have risk of incontinence. Also to quantify the effect of a therapeutic intervention, in especially there is a post-operative sphincter repair. Anorectal function evaluation is very important in obstructive trauma or traumatic injuries, especially when the patient desires to have a normal vaginal delivery. Also to facilitate biofeedback training, which my colleague Dr. Zubin will enumerate later. It has to be understood that anorectal manometry has to not be used in isolation because it would not give the desired result, and we know that anorectal symptoms are basically multifactorial in origin and may have multiple tests required to give us the desired result. So in anorectal manometry, always a test of rectal sensation has to be done and a direct test of evacuation has to be done, either the balloon expulsion test or difficography. Difficography can be barium difficography or MR difficography. However, MR difficography scores over the barium difficography. Now, initially, when the London Protocol was classified and a working group of 29 experts met in London from 2014 to 2018, they held 6 physical conferences and 3 remote conferences, and they aimed to develop an international anorectal physiology working group. Now, this was a standardized protocol for the procedure of anorectal manometry, which was previously lacking in most of the studies. They also introduced a system for disorders of anorectal function based on objective physiological measurement, and they called the London classification using the IAPWG protocol, the working group protocol. Now, this in protocol, the test preparation was giving enemas to the patient, wait at least for 30 minutes for after evacuation, place the probe in left lateral position and wait for a 3-minute stabilization before starting the recording and trying to do the test. It involved at least doing a resting phase for the anal sphincter pressure for 60 seconds, followed by short squeeze pressure, 5 seconds each, at least 3 with a gap of 30 seconds, followed by an endurance or a long squeeze for 30 seconds where the fatigue of the anal had to be seen, at the cuff reflex on 2 occasions of 5 seconds, followed by an interval of 30 seconds, and the push maneuver or the defecation, stimulated defecation, which involved push over 15 seconds with a 30-second recovery interval over 3 things. Now, it's followed by a direct sensation test, rectal sensory test, in which they use 3 parameters, and the rectoanal inhibitory reflex. Now, if we look at the London classification after this protocol, the resting pressure was basically the mean maximum pressure over the whole anal canal over 60 seconds. It was included in the London classification. The squeeze pressure, the long endurance was actually not used, but it was a voluntarily sustained to increase an anal pressure and get in 50% of maximal incremental squeeze pressure during the long 30-second interval. The rectal push pressure, this was a rectal pressure change and also an anal pressure change during push. This was included in the London classification. The cuff reflex was not included. The RIR always has to be included, followed by the balloon expulsion test and the rectal sensory test, where there was a first sensation. Now, rectal sensation is basically the first sensation a person would feel, followed by a desire to defecate. Now, this is to be a constant desire to defecate and a sustained desire to defecate, not just you feel the initial desire to defecate, followed by a maximal tolerated volume with which the patient had an urgent or an intolerable desire to defecate. Now, this protocol, after the resting pressure, looked at four aspects: the short squeeze, the push, the rectal sensory testing, and the RAIR. Now, this classification using this protocol gives diagnosis in four areas: disorders of rectoanal inhibitory reflex, disorders of anal tone and contractility, disorders of rectal anal coordination, and disorders of rectal sensation. We look at the examples of each. This was a hierarchical division similar to the Chicago classification, where it was classified in major findings, minor findings, and inconclusive findings. The major findings are never seen in healthy population and would represent the disease state. Minor findings have to be in conjunction with other tests. They could be seen in patients with healthy subjects and may represent a physiological alteration. And the inconclusive findings where both healthy patients and patients would have these symptoms, but the relevance was not clinically understood. Actually, this was the limitation, that the classification could not bring about the changes which would require in inconclusive findings. So the major findings were rectoanal areflexia, anal hypotension with a normal contractility, anal normotension with anal hypocontractility, combined anal hypotension and hypocontractility, rectal hyposensitivity, and rectal hypersensitivity. The minor findings were anal hypertension, abnormal expulsion with a poor propulsion, abnormal expulsion with dyssynergia, abnormal expulsion with poor propulsion and dyssynergia. And inconclusive findings were abnormal expulsion with normal manometric pattern of rectoanal coordination, or a normal expulsion with abnormal rectoanal coordination, and borderline rectal hyposensitivity. So looking at the London classification, the first thing was to look at a RAIR. If it is absent, then it is always considered abnormal in the clinical setup, except when there is megarectum or there are dementia patients, in which it has to be understood in the clinical aspect. If you looked at the anal tone and contractility, then it is always a major findings. You look at the resting anal pressure. If it is more than upper limit of normal, then there is anal hypertension. Look at the anal resting pressure. If it is less than lower limit of normal, look at the anal squeeze pressure. If it is also less than lower limit of normal, there is a combined hypotension and hypocontractility. Whereas if the anal squeeze pressure is less than lower limit of normal, not less than limit of normal, then it is an anal hypotension with a normal contractility. These all cases were different in patients of fecal incontinence. Or if there are normal resting anal pressure but the squeeze pressure is low, then there's an anal normotension with hypocontractility. Now, if we look at the London classification for looking at rectoanal coordination, the first test is a direct test which has to be evaluated in interpreting the results, whether there is an abnormal balloon expulsion, that is a 50 cc water-filled balloon can be expelled in normal time. Now, the limitation of this London classification was that the results could be not extrapolated in every machine from the manufacturer. Each machine should have its own normative data generated, and this they accepted as a limitation. And there are studies to look into this aspect. So if the balloon expulsion test was abnormal, then looked at the rectal pressure changes during the push pressure, which is greater than the lower limit of normal. Now, it is always a rectal pressure increase and not the absolute pressure increase. Then you look at the anal pressure decrease, whether this is considered as a relaxation. If both are normal, then it is an abnormal expulsion with a normal manometric pattern of coordination. Similarly, if the anal pressure decrease during push is greater than lower limit of normal, then it is a norm. And we also similarly have an abnormal expulsion with dyssynergia. Similarly, if the rectal pressure during an increase is greater than the lower limit of normal, but the anal pressure is changed. The anal pressure decrease is during push more than the lower limit of normal. It's only an abnormal expulsion with a poor propulsion, which means the rectal pressure is poorly propelling. Similarly, if both the anal pressure decrease is greater than the lower limit of normal and it is not there, there's only an abnormal expulsion with poor propulsion and dyssynergia. At looking at the rectal sensation, There were three parameters which we have seen, and if two or more of them are greater than the upper limit of normal, it's a rectal hyposensitivity. It's always a major finding. If only one of them is there, greater than the upper limit of normal, it is a borderline rectal hyposensitivity. And if the rectal pressure, if one or more of the sensory parameters are less than the lower limit of normal and it includes the maximum tolerated volume and only one parameter, or then it is considered as a rectal hypersensitivity. So the limitation of the London classification was it was an expert opinion and not a direct clinical evidence. It was a proposed approach and not validated at the time it was published. It was understandable, but this was because of multiple factors contributed to the symptomatology, so could not be used in isolation. Thank you for your patient hearing.
Thank you, Dr. Manish. You can join us here. We'll have questions at the end. For another interesting talk, and the hot topic is biofeedback, I would like to invite Dr. Zubin Sharma from Fortis Hospital, Gurgaon. He will tell us manometry, how he does it, and how it should be done. Welcome, Dr. Zubin.
So at the outset, thank you very much for INMA, Dr. Srihari, Dr. Arora sir, for having all of us here. I think it's a testament of the whole years and years of hard work by the INMA that we all are here together to talk of a very niche topic. So today I'll talk of biofeedback and biofeedback, how I perceive it and how I do it, and there can be variations in it. So the first thing that I want, if a single message has to go across, is that biofeedback is a tailored management. It's not one size fits all. It's not something that you're gonna try to fit into every patient. Every patient will require a different kind of algorithm to go for their therapy. So a very, very brief about basic physiology. I'm sure you all are aware, but this is important because this you have to teach your patient also. If they do not understand the basic physiology, they will not really understand what we are trying to tell them. So in a very brief way, internal sphincter is the chunk of your basal tone. External sphincters contribute around 30%, and rest is by the hemorrhoidal plexus and other muscles around it. And in case there is some abnormality, the accessory muscles will take over the function of the internal sphincter. So all this becomes very important if you have a patient who has an internal sphincter injury, who has incontinence, who is coming to you for biofeedback. So remember which muscles we really have to work on. Then phases of defecation, I think we all are very much familiar with defecation process, but just to give a very brief overview, your colon is the one which actually starts the process. The rectosigmoid breaks will slow it down. The rectum fills it up, and then finally we have the expulsion process. So everything starts from the colon. So we're going to use this as timers for our patient when we ask them to come for biofeedback therapy. Now, coming back to the core topic of biofeedback, so we all know it works. Have been enough randomized trial by Dr. Rao and his group in US that it works very, very well. Even with us in India, we have seen it works around 60-70% in good centers. The improvement is not only in the constipation symptoms, in the dysphanergic symptoms, but overall and the patient whole. So why should we even think of biofeedback? Why should we not just give laxatives? So if you see the strength of evidence for patients for short-term and long-term therapy for dyssynergia, it is level 1 grade A evidence. So we should not be loading them with laxatives at what sir said in the previous talk. Our evidence is for biofeedback. And if you're doing anything else than that, we are not following evidence-based therapy. If you look into the publication, it has really increased in last few years simply because of this reason that it's a level 1 evidence. Now, how do you start planning for biofeedback? You need to have a good room, good place where you can give adequate privacy to the patient, appropriate washroom nearby. I do it in this way, at least 2 screens in front where a patient can have his own screen where they want to have a visual feedback, as well as for my screen where I can see what they are going wrong. Further, this is how an actual final report will look like. You give them a report over 2 or 3 sessions, 5 sessions, where you can show them that how much improvement they have done in their rectum and how much, including in the anal canal. Why is this important? Because until you show this to them, they will not come to know what they are doing better. So the goals are to improve the bowel function. It's kind of an operant conditioning method. You have to correct the dyssynergia, you have to facilitate normal evacuation, and you have to improve the sensory perception also. So there are 3 phases given by Dr. Rao. The first is the patient evaluation and education. Then you have an active phase, and then you have the maintenance phase. The most important thing you have to understand is the patient evaluation and education is the most important part. You need to tell them about stool diary, the normal physiology, the diaphragmatic breathing, the time toilet training, and protocols and goals. The active phase actually is around few sessions, 5 to 6, and you have to give them a feedback. And finally, you have to reinforce all these methods over a period of time. So these 3 phases have to be there for almost a complete therapy. How I do it is what I follow at my place. The session one again tells me I spend an hour and a half with the patient just trying to understand their work, their lifestyle, their food, what are the stresses, what kind of work they are in, what is their home, what kind of washroom they have in their home, how do they use their food to go to the washrooms, what kind of medication they are on. So all these things I learned in the first session, and I maintain a diary for each patient. Once I have that, I have to make sure that they are not impacted at that point of time. If your patient is impacted, you can't really give them any biofeedback therapy. So some laxative use has to be there in the beginning so that they are not impacted while we are doing it. Then, based on what I have seen on the manometric findings, I start training them. Ideally, if you have a commode, that's the best way out. Otherwise, left lateral also, at least logistically, makes things easy. You correct the posture. You ask them you explain to them the basic anatomy. You train them for diaphragmatic breathing. You ask them to go back home and again do it. You ask them to squeeze and relax while giving them a feedback. You distend the balloon and give them a sense of rectal fullness and again ask them to do the same things. All this will go on in the first or 2 sessions itself. After they have achieved some amount of improvement, that is at least a 10-15 mmHg fall in their baseline basal inner tone if they have hypertonia, then you go on to add the simulation defecation training to them. By that time, they must have improved their abdominal tone by diaphragmatic breathing also. So that will help them to improve their push. So now you have to teach them how to coordinate the push as well as in a relaxation. How I do it, I keep a hand on patient's tummy and I ask them to push now and I feel the tone of their abdominal muscles. And then at the same time, I see on the manometry screen whether the inner canal is relaxing or not. I'll show you on the video also. And after they are improved, they have got their synchronization around 4th or 5th session. I give them a small Foley, which I learned from Dr. Nisarg, that I attach a small balloon in the front and that they can use at home for their defecation exercises. So this is all in a stepwise manner that actually goes in of various sessions. Session 1 and 2 are the most important to establish a rapport with your patient on how do you really want to work it down. Then there are some exercises which you can also tell them. These are based on various, by physiotherapists as well as from our own books. This can be used in your patients as well. We have papers which actually give a very nice way of exercising by Dr. Venkataswa, and we can do the pelvic floor exercise protocols also. This is something which all should be a part of your protocol along with the actual sessions that they do in the hospital. So how do you use it? Your biofeedback, I think in the initial analysis, you have to first of all see on the manometry, you need to learn the London classification where what Dr. Manish Paliwal told us, use that classification to plan your biofeedback. If you have a patient who has poor inner relaxation plus poor push, both the things have to be worked on. If you have a patient who only has a poor push, you work on that. So in the beginning, I said it's a customized, tailored treatment. So your London classification, the advantage is it actually tells you what is the mechanistic cause of the constipation or the dyssynergia. So this mechanistic cause can be utilized in biofeedback therapy. Finally, when you have to start the biofeedback itself, how we initially do is we start with the squeeze training. I'll just forward this here. So this is how the screen actually looks like on one of the manufacturers. You wait for some time, let the baseline be set. Then you ask the patient to squeeze and relax. Once you was now which target to give. If the squeeze during manometry was around 120, you can't ask them to keep on doing 120 mmHg itself. You have to give them a higher target. So for that, you increase the pressure to the pressures around here to around 250. That gives you an adequate challenge. They should be approximately 30-40% more than their baseline squeeze. That's when they will try to achieve a target, and that will lead to inner canal relaxation. And finally, when a couple of sessions have done, you will see a slight fall in the baseline pressures of around 10-15 mm of mercury. That's when you know they are ready for a defecation training. For the defecation training, once you move, this is how the screen will look like. Sorry, just one second. This one. Yeah, so this is how the screen will actually look like. So you will have on the one side the inner canal pressures, and the other side you will have the rectal pressures. And this is where you will start teaching them how to synchronize both things together. Use your diaphragmatic breathing. Once you have increased, you have a deep inspiration, then try to push it out and relax the anal canal. Keep your hand on the tummy to really understand that they are doing it well. That gives you a good tactile feedback on your hand itself. And finally they will start doing the push nicely. As you can see on the screen, this patient has started to relax the anal canal a bit, and they are trying to pass the stools. Sensory training is more difficult. The outcomes are poorer. The intermittent inflation of the balloon in the rectum, you go to the highest volume that they first felt, and then keep gradually bringing it down by repeated inflation and deflation. But it's not something, it's more difficult to train than dysynergia alone. The duration, the training sessions are performed in my hospital at bi-weekly. It can be more depending on if the patient is outstation. It can be done rapidly also. Each session will take at least an hour. Average around 4 to 6 sessions are required, and periodic reinforcement is definitely needed. When to stop? When patient has demonstrated a consistent coordinated pattern of defecation with anal canal relaxation, the stooling habit has overall improved. The symptoms of the patient, whether it was bloating, constipation, dysenergia, that has to improve before you stop. Just passing the balloon out is not the target. So balloon expulsion time has to be normalized, and patient symptom has to be normalized. For incontinence, the pelvic floor strengthening exercises are important. You have to use Kegel exercises, some visual and verbal feedback, squeeze and maintain that squeeze for as long as possible. Train them for that long sustained squeeze. And finally, you can discontinue when the incontinence episodes store. So thank you so much for patient listening.
Please join us here.
Yeah.
Now you can ask the experts any questions. If you have any comments, they are welcome.
May I invite Dr. Matthew, sir, also on the stage?
It was a wonderful presentation, Zubin. I have one question for you. In biofeedback, if you feel if you find the defecation index is very poor, in the sense it is very low, so do you preempt that these patients will need more sessions? Can we say that you are going to have higher number of sessions looking at the defecation index at the first go?
Yeah, so no, I didn't cover that which patients are the ones which will not respond very well. So the poor patients, in my understanding, is the one which are more, elderly. They already had some structural changes in their ligaments as well as in the muscles, and they have a rectal hyposensitivity. If your defecation index is, what you were saying, and you can tell them that, of course, they're going to take some more time, but you have to be more patient with them.
True.
But if you feel that on manometry and your good peer examination that the overall muscular infrastructure is not right there, they definitely are not the right candidates for biofeedback. You have to tell them you have to be on laxatives for a longer period of time.
Thanks.
Hello, good afternoon. I'm Dr. Syed. Thank you for all the amazing lectures. My question is to Dr. Manish. This is regarding balloon expulsion test on rectal, anal manometry. How reliable can we say whenever there is failed balloon extraction? Because almost all the times we do in the lateral position, but natural position is on the commode. That's not the natural position. So once there is failed balloon expulsion, can we label it as poor propulsion always, or should we wait in the clinical context?
Balloon would be an expulsion test. Now, if this is a direct test of expulsion, so if you are doing in a left lateral position, there is data that it is as good as sitting in a commode. However, you can also relax the patient and do it again before you decide. And you can also, if I, in fact, in my lab, I also have a commode with a curtain where I let the patient expel, and we can figure it out on the machine whether he has expelled. So trying both times is a good a way. And if at all he cannot expel, then it is a poor expulsion. That's true. Abnormal expulsion.
Okay, thank you.
My question is to Manish. You have so many variables when you are trying to classify the anorectal disorders using the London classification. And then you have so many different results. And you said at the end of your talk that this has not been scientifically validated as yet, at least mechanistically. So, how do you simplify it for the people to understand the logistics of the application into clinical practice?
So basically, this protocol was first designed to produce a standardized reporting or a procedural aspect. Then the London classification was made as an expert opinion from about 29 experts who were for last 4 years looked into this aspect. They developed certain criterias and removed certain criterias, like they do not look at the rectoanal gradient. They do not look at the absolute decrease or increase in pressure. They look at the maximal changes. So based on this, and they acknowledged in their limitation that this is an expert opinion, it has not got validated the time they wrote it, and people are looking into it. In fact, there is a paper from India also by Dr. Akash Shukla and group, that they are looking at the normal manometric patterns. Now, this London classification also looked into each machine. So ideally, they say that no machines can be compared and you should generate your own normative data. Just give a guide map or a protocol from which we can do the test and interpret the data in the clinical context. And they acknowledged that you cannot create a validated approach just based on this. You have to look at the whole multiple factors. For example, like if there is a rectal hyposensitivity, then you do a barostat, do adjunctive test before you can finally conclude in the clinical text.
And Zubin, you said that you have to tailor made. You see, there are so many components to the symptomatology. You will have anal hyposensitivity, hypersensitivity, failure of relaxation, too much of a pressure tone, anorectal dyssynergia. How do you tailor made unless you have objective evidence of problem in one of the components? Otherwise, we presume that it is all a functional disorder which can be tailor made. Is there any organic component to it? Say inflammation in the sphincter or fibrosis in this or a particular amount of different type of dyssynergia. So if there are so many components, how do you tailor made?
Yeah. So, sir, you very rightly said there are so many variables that can be affecting a single patient. So, what we try to understand is what is the pathophysiological process in my patient. For example, if patient may have a poor push from the abdominal wall muscles, that's where I want to work first. He may also have a rectal hyposensitivity, where while I'm working on the push, I'll probably give him some medical management for the hyposensitivity. Similarly, if you have a poor inner relaxation, you will work on that. So when I say tailored, I mean that while you are doing manometry, you identify which is the predominant mechanism and you start working on them, because as you said, a single patient can have multiple variables. And that's also an extension of what you asked previously about the London classification. London, the only use I see of it is that it tells me where I have to work on. That's the best use of London classification.
And is it a one-time solution or the patient continue
No.
to have problem later
So
on?
as I said, sir, it has to be reinforced. You have to have that last maintenance phase over a period of time.
My question to Zubin
We'll
sir.
have two short questions only.
My question to Zubin sir.
Yes.
Uh,
I would like to add some more points into that. If you have a pelvic floor physical therapist in your team, the certified pelvic floor therapist, if you refer, we can also do the evaluation of the abdominal muscle assessment and then pelvic floor biofeedback assessment by keeping the rectal probe, by analyzing the internally placed muscles, and also per rectal examination, we can assess the tone of the puborectalis, pubococcygeus, ileococcygeus, even obturator internus, we can assess the tone and understand when there is increase in tone. Okay, and then because of, since physiotherapists are trained in assessing the myology, muscle physiology, muscle kinematics, we are all trained 4.5 years course followed by post-graduation and also specialization in pelvic floor physical therapy. So we have a structured program. So if you have a pelvic floor therapist in your team, we can work as a team. As a doctor's gastroenterologist, motility specialist, when you do the diagnosis in anorectal manometry and then refer that patient, we can all work as a team, and we can also do the assessment in the pelvic floor therapy using biofeedback assessment, internal examination. We have a SOAP format where subjective, objective, assessment, and plan, and we send you a report on the day of evaluation, midterm report, and also the discharge. These patients can be seen once a week for 10 weeks. So we have treated about 382 patients in last 5 years with very good results, 82% of results with positive. And also studies have shown that the pelvic floor muscles has to relax for 60 to 90 seconds for proper evacuation, fecal evacuation problem, outlet problem, dyskinesia problem, all because the pelvic floor muscles are not relaxing in the functional position. One doctor was asking a good question where it's not been done in a functional position. So we do the rehabilitation in lying, crook lying, on four position, sitting position. In sitting position, most of the Indians are now converting into the Western toilet. Only in the rural areas we have Indian toilets. So we create an Indian toilet atmosphere by giving a step stool or a scooty potty, so that we are creating a proper anorectal angle. Normal angle is acute. When there is evacuation, it becomes obtuse. So we can analyze in so many possible ways and give the training in a functional position, so that functional constipation can be addressed efficiently.
My question to Zubin sir. Are there any parameters on anorectal manometry which you see in the first 1 or 2 sessions which you think that there is going to be a failure to the biofeedback therapy, number one, or any additional drug therapy you advise, such as neuromodulators, along with when you start the biofeedback, which might help in the predicting the response, promoting the response?
The most important thing I say is if patient has a very significant rectal hyposensitivity, those patients usually don't respond very well. You have to give them some drugs along with them. Secondly, on a PR, in fact, not on manometry, but on a PR examination, as I said, there are patients with dyssynergia with a poor anal tone. If they're doing a finger evacuation and there are a lot of muscular and ligament things already kind of taken place inside, those will not do well. On manometry itself, you can see if patient the anal canal is completely not like relaxing, but the push is still very high, those will not do very well. So there are some small markers, but sensitivity is the most important thing which leads to a failure of biofeedback.
Are their volumes fixed?
I have a question to.
Are the balloon volumes fixed?
Yeah,
as we're running late, I think we'll have just 2 more questions from.
I have a question to Dr. Zubin. Thank you for the talk. Just one aspect that we face while we do biofeedback in patients. When you keep targets, basically when we go for biofeedback, we keep targets. So the software gives a target of decrease of 30 in the rectal, increase of 30 in the rectal push and a decrease of 20 at the same simultaneous on the anal for as normal. That's what it says. But some patients have a baseline high anal tone. So when we reduce it by 20 absolute value of 20, when we reduce it, it does not come below the rectal pressures. it might be still above the highest rectal pressure. So how do you assign targets for each session?
So as I said, you have to use your manometric findings of that patient to assign the targets. Don't go by what the machine is telling you, and don't go by what targets given by the machine. If your anal tone is already 70 and the squeeze was, let's say, 110, and you keep a target of 110 for squeeze, they're going to achieve it very, very easily. So you have to keep it at least 30% more than what they have done on the squeeze. And similarly for anal canal relaxation. So 20% relaxation.
We'd like to close the session.
Just one question.
Because last question, short
Everybody's
question.
talking about rectal hyposensitivity. What are your thresholds? How do you manage that with dyssynergy, without dyssynergy?
As I said, that this classification, we have to have a normative data. So if you have a normative data, then only you can categorically say that this was normal for you. However, for dyssynergia, the anal contraction pressure is higher. So therefore you have to work on that target and try to decrease it.
I'll answer. Read a paper that was published in JGH by South Korean group. The first sensation target, the urge target, and the maximum tolerable target limit. So first sensation, if it is more than 80, the urge volume is more than 150, and the maximum tolerable volume more than 250. Any two of these three present means rectal hyposensitivity. Now, how to actually address the rectal hyposensitivity? You have to do sensory biofeedback, where what you do initially, you give the patient the target volume. Then the next session, you reduce the volume. Still next session, you reduce the volume. And the second thing, there have been some data that if you use electrical neuromodulation, for example, transcutaneous electrical nerve stimulation of peripheral branches of sacral plexus, then it may improve.
Thank you very much.
Ma'am, to Manish.
No, please, because we have to wind up the session. We thank you all for your active participation, the speakers, the chairpersons, and the audience, of course. Thank you.
Thank you all the moderators, the chairpersons, and the speakers for such insightful discussions.